Hey folks, sorry, finally here is your video on the spinal cord, and we've been touching on the spinal cord already somewhat in class, and we're going to do just a little bit more with it, but I wanted to finish up here with some issues related to spinal cord injury and disease. Give you a second for the cartoon. There you go. So first, let's remind ourselves of this. The spinal cord in a cross section is not going to have these blue and red regions clearly, and it's not even going to have even very clear distinctions between all of these different tracks that you see here. Think about tracks or columns as just roads. Some of the roads travel north to south, some travel south to north. The ones that travel north to south are descending tracks. Those are the ones that are here in red, are motor tracks. So information is traveling from the brain through these tracks in the spinal cord to different motor nerves, where they're going to influence the actions of glands or muscles, for example. The blue represent ascending sensory tracts, so afferent tracts. So I'll point this out because this is one of the spinal cord's functions, is to be this nerve, this highly specialized nerve pathway. The other job is to propagate nerve impulses. Well, sorry, one job is nerve impulses. I shouldn't read when I'm doing this. And the second is to handle reflex traffic. And the reason I mention reflexes now, even though we're going to talk about reflexes more in class, is one way of diagnosing or determining spinal cord injuries is often to look at reflexes. If somebody's unconscious and you're trying to determine spinal cord integrity, you can't ask them to move something, but you can test reflexes, and that can give you some indication of how bad a spinal cord injury may be. So what I want to do is touch on a few diseases and talk a little bit about trauma as we look at the spinal cord, and we'll look at stenosis and spina bifida, but I also want to talk a little bit about trauma and just give you some terms here. Obviously, when we're talking about paralysis, I'll talk about the other ones in a second, but paralysis means lack of function. So someone can have paraplegia. That is, they cannot move their legs, but they have arm function. They could have quadriplegia, which means they have no movement of their arms or legs. Plegia means not to move. And then usually we associate the extent of the paralysis with the location of the trauma. And we'll talk about that more in just a moment. Just one more term that you may not have seen before, but paresthesia means a loss of normal sensation. Someone could have a spinal cord injury and they're left with this tingling sensation, like when your arm goes to sleep. That might be how they feel all the time. So it's a disrupted, irregular form of sensation. So you can have spinal cord injuries that result in not much injury or not much long-lasting injury or issues to something that gives you some kind of intermediate, like this paresthesia, leading all the way up to paraplegia or quadriplegia. So a variety of outcomes for spinal cord trauma. We'll also mention polio. We won't touch on meningitis again, but we'll remind ourselves of the issues with polio in just a second. But first, let's talk about stenosis and spina bifida. Whenever you see the word stenosis, that means to narrow. It means that some opening is too small. If someone has vascular stenosis, it means their arteries, for example, are too small. In the case of spinal stenosis, here's what we are expecting to see. We're expecting to see a nice, healthy spinal cord with all the meninges and within the vertebral foramen, but somebody could have spinal stenosis, which means that opening in there, that gap, is too small. Notice you may see what appears to be extra epidural fat in here. You may also notice extra bone growth, and you see kind of the pinching on this nerve and the pinching on this base here, which then compresses the spinal cord. Where does spinal stenosis come from? It can be congenital, and let me give you that term. Congenital means you're born with it. So some people can be born with a form of spinal stenosis. Other people, like you're seeing here, develop it over time. Spinal stenosis is associated with aging. It's a degenerative disease, and most people who develop stenosis develop it in this degenerative fashion. They may get older and notice some tingling in their arms and legs, fingers and toes. They may notice some numbness, some weakness, and that could indicate stenosis, as you see here. And it can be corrected somewhat surgically depending upon the extent of the stenosis. The two most common locations for stenosis, lumbar stenosis, so someone has stenosis of their lumbar vertebrae, and as you might imagine, that's going to impact them from a leg perspective. They may have something that resembles sciatica. They may have pain, burning sensations in their legs, or they could have cervical stenosis, and that could give them, again, weakness. It could even result in paralysis if you have enough damage to the spinal cord as a result of the stenosis. Thoracic stenosis is pretty rare, but spinal and lumbar are fairly common. The other one I want to mention on this slide, when I get my arrow here, is spina bifida. Spina bifida is a congenital issue. That is, someone again is born with it, and this is a neural tube defect. What happens in spina bifida is when the spinal cord is growing, it's supposed to be encased by the vertebral column. And as we saw over here, I'm using my fingers like you can see me. When we saw over here, you notice how we have you're seeing here the vertebral disc, but if you were to imagine it's not there, we have more vertebrae. So the spinal cord is normally going to be encased by this vertebral column. In the case of spina bifida, and there's multiple kinds, that does not happen. It may happen not so badly, and we have a form of spina bifida called occult spina bifida, which means hidden, where someone has very minor issues because their spinal cord is not quite encased in the spinal column. Or it can be more serious, like you're seeing here. You can see, again, the meninges and spinal fluid, and I'm not showing you the more graphic pictures here, but you have an exposed spinal cord when the baby is born. Depending upon the severity of it, this is not the most severe form. This is getting there. But the more severe forms can result in paralysis, can result in loss of bladder function, can result in a number of deformities and issues. So it can be corrected somewhat surgically, depending on how bad it is, but again, they may have suffered some damage because the spinal cord is kind of exposed in the cases of spina bifida. What causes them? It can be genetic. There can be some risk factors we see in certain families. It can be caused by certain kinds of medications. Some people with some kinds of diabetes will sometimes have babies with higher rates of spina bifida, but the actual leading cause of it appears to be a lack of folate, a lack of a B vitamin in a mother's diet when she gets pregnant. And so we know when women are planning on getting pregnant, we put them on prenatal vitamins to ensure they have plenty of B vitamin, plenty of folate. Let me give you that one too. Plenty of folate in their diet, because that seems to be a major risk factor. If somebody is concerned, or just even a general screening for spina bifida, then they will typically do a test called AFP, which is for alpha fetal proteins, which actually is going to be a way we can determine if a baby may have spina bifida. If we find high levels of AFP in the blood of the mother or in the amniotic fluid, it strongly suggests that the baby is going to have some degree of spina bifida. So those are important prenatal tests. All right, so I want to talk just a little bit about paralysis that we don't really associate with trauma, and then we'll move our way into some of the more traumatic issues. If you see the term flaccid paralysis, that usually refers to damage to the ventral root or the ventral horn cells, and you'll see those in a future slide. So this may not be caused by trauma, but the result may be paralysis. Somebody can have issues related to their exposure to certain pathogens, such as polio or the botulism toxin. Even venomous snakes the venom can actually attack the ventral roots and cause damage to these roots, which then causes there to be no impulses sent to the muscles, therefore leading to muscle atrophy. So as you can hopefully see here, this is not really a spinal cord issue per se, but it's more of a peripheral nerve issue. But I mention it here as we're talking about paralysis. So again, this can be disease caused. We can associate it with trauma, but usually we refer to flaccid paralysis as having other causes besides trauma. The other form of paralysis I want to mention here is called spastic paralysis, and this is when you have a loss of inhibition of motor neurons, which causes a lot of muscle contraction. So the muscles here are going to be stimulated by reflex activity, but a person really has not much voluntary control of their muscles. So they have spasmodic, uncoordinated movements. You know, you might think of paralysis as, oh, well, that means they can't move it at all. Paralysis refers to here as they have no voluntary control. They have no way of them consciously controlling their own muscles. The muscles typically shorten permanently because there's a lack of ongoing voluntary motor control. You'll see this in like cerebral palsy, which is congenital. So, and that can be caused by a number of things. We won't get into the details, but again, paralysis refers to lack of voluntary movement. So it could be flaccid, and therefore there is no voluntary or involuntary control at all. Spastic means that there's reflex control of the muscles, but there's no voluntary control. In either case, we're talking about paralysis. Okay, so let me come back. I don't know where I went. Hang on one second here. Am I here? Hey, I'm back. Okay. I want to mention spinal shock as well as transection. Whenever we talk about spinal shock, there's going to be a period of time following a spinal injury. It's sort of like the spinal cord went through kind of a shocking phenomenon. There's a physiologic disruption in the signals, and so there may be, when you're trying to assess someone's spinal cord injury, there may be a time when you're like, oh my gosh, they have no spinal function whatsoever. And then just a little bit later, a few hours or 6 hours after the initial injury, then they may recover some function back in some parts of the spinal cord. That initial kind of resetting the whole thing is referred to as spinal shock. But as I mentioned before, when we're talking about transection, we're talking about at any level of the spinal cord, from C1 all the way down to the end of the spinal cord, we're talking about injury, transection, meaning to completely cut it. You do see here results in total motor and sensory loss in regions inferior to the cut. Again, there are slight exceptions depending upon the nature of the injury, how long it took to stabilize the injury, subsequent swelling, and the like. But typically speaking, when we talk about a total transection in the spinal cord, we're talking about total loss of functions at that point and forevermore. Again, paraplegia is going to be typically what we expect if somebody has a transection between T1 and L1. So if they have a thoracic injury, then more than likely, because of where the nerves come off of the spinal cord to control the arms, they can still have arm function, but they will not have leg function. The further you go up in the spinal cord, the more severe the injury, because the more nerves you affect. So if someone is going to see an injury in the cervical region, typically they're going to be a quadriplegic. Okay. Don't know where my menu went over here. We'll keep going with it. So in this case, when we're talking about how do we assess CNS dysfunction, how do we actually diagnose that somebody has had a spinal cord injury, and to the extent that they have. Again, reflex tests are often the best. We cannot ask somebody who is unconscious to move things for us because they're unconscious. But we actually can test certain reflexes, and I'll talk about a couple in a second. Obviously, we can do CTs, MRIs, PET scans, and the like to try to visually assess where the injury was and to see the extent of its injury. I want to show you this case, and again, I wish I could move my menu back here, but I'm going to just give you the highlights of this. Here was a 33-year-old male who was in a car accident, and when reported loss of all movement of extremities. He was wearing a seatbelt, sorry, was not wearing a seatbelt, hit the airbag, and I'll show you the mechanism of injury here in a second. On the examination, the patient had flaccid paralysis, so therefore really no voluntary or involuntary movement. of any of the limbs, a sensory level at C4. That is, at C4 and above, there could be some sensation, but not below. No sphincter control, erectile tone, an absent anal wink, no sacral sparing, and a positive bulbar cavernous reflex. And I'll talk about a couple of those in a second. So, if you notice here, and again, there it is, you notice here, this is the transection of the spinal cord. This is where the injury occurred. This is at the C5, C6 level. So, it kind of makes sense that above above this point, at C4 and above, that there's going to be some sensory function, but anything below this has been permanently cut off. This is another view of this. Darn it, my thing's moving around here. Okay, if you count here, 1, 2, 3, 4, 5. Look here, right here and right there, you see the damage. That's where at C5 and C6 appear to have some vertebral fractures. So, what were some of the reflexes we were looking at to assess this guy? Okay, anal wink. You get a visible puckering at the margin of the external anal sphincter by stroking the perianal skin with a pin. So the absence of a wink suggests that there's damage to the sensorimotor neurons. So you're not getting any signal. The other one shown here is the bulbar cavernous reflex. If you were to squeeze the penis or to stimulate the clitoris of a woman, and or you can tug the catheter with a finger in the anus, you actually can feel, and for a positive reflex, you can feel the anus contract. So again, these are reflexes that can be measured because they are giving us some estimate of spinal cord injury. Since we know where these things map, we know where the spinal nerves associated with this are. So if we don't have these reflexes, it helps us understand where someone's injuries may have occurred. Here's what the doctors concluded must have happened in this case. That the guy in question actually hit, and notice the angle of this, when the airbag deployed, it actually pushed up, and because of that, it caused the vertebral fracture. The vertebral fracture then damaged the spinal cord and transected it. The reason I show you this case is a little unusual because typically speaking, when somebody's in a car accident, they don't suffer a transection of the spinal cord. This is a rather unusual injury, and it was documented as showing how this was probably happened because of the way the airbag deployed. I want to give you this view just for a second, and I'm not asking you to go through and memorize all of the elements here, but this gives you an idea of the level of injury, the level of the injury and the subsequent damage that we associated with it. The higher up we are, and that's just the rule of thumb, the higher up we are and we have an injury, the more damage we expect, because anything inferior to that site is going to be affected. So Christopher Reeve, for those of you who remember Christopher Reeve, who was Superman in the movies when I was growing up, he suffered a horseback injury. He was riding a horse. He went over the top of the horse, and he had a C1, C2 injury. He had a spinal cord injury at C1, C2. He was lucky to live because typically speaking, you're going to have paralysis of the respiratory system. Usually people with this injury don't live very long at all, and you see here patients usually cannot cough, control bladder movements, cannot really breathe without assistance. And Christopher Reeve, in the latter part of his life, was able to actually be off the respirator for a slight period of time and be able to talk, which was again rather amazing. As the further you go down from C1 to C4 down to C5 to C8, as you get down to the end of the cervical vertebrae, then you start to have more and more respiratory control. You see the thoracic nerves. If you have injuries between T1 and T12, then people typically do at that point still have now arm function. If you go down a little bit lower into the lumbar vertebrae, they're going to have more leg function. So as you might imagine, just because of where the transection occurs, and again, remember that the spinal cord is a nerve pathway. The higher the injury, the worse the effect. The lower the injury, the better the effect. But as you see for most of these, all of these on this screen, that anyone who has a spinal cord injury typically loses voluntary control of the bladder and bowel because of just, again, where the that's controlled very low, if you will, on the spinal cord. I just want to mention a couple more things as we wrap up here. We've already talked about polio somewhat, but I want to mention this one again as related to spinal cord functioning. Even though it's not really an injury of the spinal cord itself, it damages the ventral horn neurons, so those that originate here, but the root is damaged. And again, remember, the ventral is going to be involved in motor function. So if someone develops polio is a virus. If they develop polio and it actually attacks their central nervous system, for some percentage of them, they actually develop paralysis. They may actually develop even conditions related to respiratory impairment, which can even lead to death because it paralyzes their respiratory muscles. And even some people, after they recover from polio, can develop what's called post-polio syndrome, where years later the muscles get even weaker unexplainably. We don't know what causes it, and we can't really fix it. And finally, one I want to mention that we've already talked about as we looked at diseases related to muscles, but one more time to mention ALS, Lou Gehrig's disease. Once again, we're talking about the damage to ventral horn motor neurons, and the symptoms are progressive. Typically, they have death here within 5 years. It depends upon how fast it actually progresses. 3 to 5 years is pretty typical. And again, when you see those terms caused by environmental genetic mutations or environmental genetic factors, it means we don't understand most of the cases here. Only 5% of the cases of ALS are shown to have a genetic link or family history. 95% of them, we don't know what causes those cases. There are very limited treatment options, and nothing can cure ALS. So what I wanted to do in this video is just kind of take you back through that discussion of the spinal cord's major functions, look a little bit at what happens when you have an injury, and then we'll talk about a little bit later in class and in future videos reflexes in more depth. That does it for this video. Thank you very much.